Thank you. Thank you, Bansi sir, and very good morning. uh, uh, I really wait 4 or 5 years to become a speaker in this conference. So thank you for giving the opportunity. Although I am a speaker everywhere on the different forum, national, international forum. So, but thank you to you, sir. Friends, topic allotted to me is a very common rethink of heart failure beyond ejection fraction. I mean, we know the all classification of heart failure depend on the ejection fraction. Either reduce ejection fraction, mid-range, half-PEF, improve, whatever it is. But practically, what the difference that is the more important in our practice. So I'm coming with this example and making it more practical. Suppose in our OPD we have three set of patient. Patient A complaining my ejection fraction is 30%, but I am well walking 400, 500, 1000 meter doing my work routinely. I am comfortable on my routine work and there is no obvious sign of heart failures. Patient B, ejection fraction again 30%. He is coming, no, I am little bit dyspneic, sir, like in NYHA class 3 like this. And while walking 10 to 20 minutes, I have some sign of a symptom of heart failure and you examine this, having some problem. Right side or left side heart failure. And patient C, again ejection fraction 30%. He is dyspnea on the rest and well established feature of the CHF and orthopnea. So where we are standing just thinking for the ejection fraction. And what the ejection fraction, just a simple arithmetics. Suppose that for one patient A, end diastolic volume is 40 ml and end systolic volume is 30 ml. So if you calculate your ejection fraction 40 minus 30 upon 40, it is ejection fraction 25%. Suppose patient B, end diastolic volume is 40% and systolic is 60 ml. Again you calculate ejection fraction, it is 25%. So what's the difference? Difference is the stroke volume. Whatever amount is going to pump in the periphery. So believe me, ejection fraction is the one entity, but always look beyond the ejection fraction. That is very important. So why there's a huge difference in the clinical finding in the same ejection fraction that is coming in the context, and this should be addressed. And our physician friends don't see only the EF is 60%, you are all right. You go and enjoy your life. Triple vessel disease having ejection fraction 70% because you are looking patient just is lying down in comfortable position. Unstable angina patient, non-STMI patient, EF is a very good. What is problem? So think beyond the ejection fraction. So two things is the important, and while we as a cardiologist doing the echo, this is our responsibility to mention this entity is the load dependent. Only load independent is when we are going vertically death. So all entity what we are doing, this is the load dependent, preload, afterload, BP and pulse rate. Just make it simple. 1% of EF 30%, we do echo at the heart rate of 120 and atrial fibrillation. Imagine how coronary filling is reduced in that patient. And in one patient 30%, EF is 70 and sinus rhythm. How is coronary reserve is good. So when you are looking for this half ref, mid-range as pre-ejection fraction patients, you also look for that what rate this done and the diastolic parameters. So 3-4 things is the important: left atrial volume index, E by E prime, that is the filling pressure, pulmonary capillary wedge pressure, and the LA strain. Simple. Ejection fraction 30%, grade 1 diastolic dysfunction, E by E prime 8. He will be all right. But ejection fraction may be 40 and grade 3 diastolic dysfunction, restrictive pattern, high end filling pressure. He will be dyspneic on the rest. So go beyond the ejection fraction, and in the systolic function also, if your cardiologist is keen to know, he should mention this sphericity index MPI, GLS strain is a good option and other relevant factors. So this is some basic pathophysiology differences in the HFrEF and the HFpEF. In the one spectrum of disease, there is ectatic dilation of the cavity and uh, muscle fiber is usually thin and atretic, and this is the reason in the HFrEF patient there is a more and more value for the anti-proBNP because this is released by the stretching of the fiber. And the HFpEF, the main pathophysiology is the fibrosis. Even in the diagnostic criteria mention anti-proBNP, but strongly I am condemning in the HFpEF you never finding anti-proBNP more than the 1000, but in the HFrEF you can get 1000 and 1005, 10, 20, whatever it is, because their cavities are dilated. So in the HFpEF the value is only when you are getting some marker that shows the fibrosis. This is some how this pathophysiology develop in the development of this. Coming to HFpEF, there is LV remodeling and some functional result changes is there, abnormal hemodynamics, secondary organ dysfunctions, and there is when you are diagnosing the HFpEF, you should be established 4 things in your practice. Either patient having some structural changes in LV, concentric hypertrophy of left ventricle, LA enlarged, LAVA more than the 34, E by prime more than the 14. And all these patients not meeting, only 40-50% patient meeting this criteria because this HFpEF is some kind of heterogeneous disorder. So here the LA strain is very important to calculate LA strain, and LA strain just reservoir strain, and you can see it how L is going to behave. So this is a multifactorial mechanism. This is some so we can't explain with the one things. So underlying cause COPD, lung disease, R&F, anemia, renal dysfunction, aging, obesity, sarcopenia, all is related. Concern is right diagnosis and starting prevention and risk stratification is the important. This is different trials with this HFpEF, high weight Ecard value alert. I will not go into detail, and they compare the mortality almost equally to this HFrEF patients. So symptom and sign, if you see combined, there is no major difference that we can say this is a symptom and sign of HFpEF and HFrEF. All percentage chest pain, shortness of breath. Usually what happen in just a couple of minutes in the concentric hypertension heart disease, what is happened practically? Concentric hypertrophy of left ventricle, LA dilated, LV is hypertrophied. Patient coming to us shortness of breath and chest pain. We are going for epicardial coronary artery, and this is might normal. And patient having ischemic chest pain and shortness of breath. The problem is the microvascular ischemia in the HFpEF patient, and that usually ignored. So we are not concerned with the only epicardial coronary artery when we are looking for especially heart failure, the preserved ejection fraction. Think for the microvascular tree, and to demonstrate microvascular ischemia in the setup when we are working in some poor subset and poor country. So this is a difficult issue. The clinical diagnosis is important to making this. This is a diagnostic algorithm for this preserved ejection fraction. As mentioned, EF should be more than the 50%, but this is the, I mean, Daesh one statement from 50, 60, 70, but usually when you see the in the HFpEF patient, ejection fraction is normal or super normal. Reason behind this is the cavity is shortened and muscle is hypertrophied. So your stroke volume is reduced. Beyond this, you will see there is increase E by A ratio, TR velocity is the high, and PA pressure is the high. BNP anti-proBNP is the high, and if patient in the atrial fibrillation, this raise further. So when you want to diagnose in our practice, just to getting this HFpEF patient, just very simple to H2F PEP score, heavy hypertensive patient with atrial fibrillation, pulmonary hypertension, elderly and high end filling pressure. This total only heavy and hypertensive having this obesity is a 2 point. In all this algorithm, you see if someone is obese and this era of obesity, so when discussion is going on, so this is a 2 point, and if someone is having a score more than 4 or 5, definitely is having the HFpEF, and you treat accordingly. There's the other score also, so but at least you should apply only one in your practice. So Coming to treatment part, you use all kind of medicine. This some different charms, pep, champ, pipes, and top cat. And regarding FPFM, this shows there is no net improvement in the mortality and the morbidity. So concern was you reduce this and use the underlying cause. But after this, coming to era of the SGLT2 inhibitor, and that's why we know this AMPA and DAPAL is the drug of choice for this FPF patient also. And reason behind it is this is having the pleiotropic benefit. This is one molecule that having on the three axis of this mechanistic benefit. This reduces the preload, what we calling EIV by prime. This causes LA volume index. This reduces the LV mass and reduces the afterload, so improve the mechanistic contraction. So one molecule, either I'm not going to AMPA, DEPA, and so on. So this having three benefit, and with so many pleiotropic benefit everywhere, oxidative interest and stress is there. But when you are prescribing this AMPA or DEPA, so you are attacking on this three axis of this patient, and you are getting in all this. When initially this molecule was launched for this HFpEF, so this shows benefit in the HFrEF patient, that's why this was launched. So with the preserved ejection fraction, there is a rule of 20, there is a 20-21% net reduction in primary and secondary endpoints with the emperor preserved trials. With same with the dapagliflozin also, this improved the KCCQ score. And coming to Orni preserve, this is one Indian study, and this from this PGI Chandigarh, and this shows when you are using this Orni with a different group of molecule, then this shows this KCCQ scores and improvement in the quality of life. So SCCN and a recommendation came that we know foundation 4 pillar therapy, 5th pillar, 7th pillar, and then subsequently more pillar will come. I will come with some new slides also. So this is a recommendation regarding this HFpEF, that you use the diuretics and SGLT2 inhibitor, ARNI, MRA, and ARB. Regarding this ARNI, you should make it clear this paradigm HF trial with the preserved ejection fraction, it was failed. Only this was effective in two subset of population, in the female patient and with a low level of ejection fraction. When EF was around 50 to 55%, and the female, this was little bit effective, but higher end of ejection fraction, this was not effective. But after this, coming to subsequent drugs, newer verisuagat, fenrenone, and some newer molecules. So this is a newer molecule that is coming in the markets, and maybe some is already, that is a myosin modulator, solvable guanine cyclase stimulator, serotic therapy, plasminogen activator, inhibitor, endothelin receptor antagonist, and some mitochondrial targeted drug therapy. So not going details, you know that interleukin is a very important culprit. So whatever way you reduce this interleukin, you are having better outcomes. So with this shows with the CANTOS trial, this causes also reduction in HSCRP level. Some monoclonal antibodies also is effective in this. Then myeloperoxidase inhibitor, this imetiprestate is reduce the myeloperoxidase and having better outcomes. Then step HFpEF program, this using this EF was typically 45%, and while using molecule, this improved KCCQ score and the body weight. Regarding this semaglutide, never host in this management of HFpEF and this SGLP1 receptor analog. So this having definitely benefit on this anti-proBNP, but this have not directly taken the mechanistic benefit of the LV myocardium or the contractility. Make it sure these have tremendous benefit on the inflammatory marker, but not improving the ejection fractions. Summit trial, tirzepatide, fenrenone, the Fidelian figure trial is came, and this is supposed to be a very promising molecule in the future for this FPF molecule, and few data is already there, and we are using the selected patients also. Fine art also redefines. Relaxin is the one that you can use this antioxidant, anti-apoptotic property, and last one, some surgical treatment, because you usually have patient having this atrial fibrillation. So surgical ablation, and for the ectopic foci is the one concern to surgical ablation. And the atrial fibrillation is the important one. So, and having the good primary endpoint in this CV death and stroke. So thank you. This all from my side. Welcome for any comments and question.